Good morning. This is Andy Reese, Director of the Department on Disability Services. Oh, it's good afternoon, sorry. We received no questions today, but as last week, I expect we'll have a conversation for the next hour, even without starting with people's questions. I'll start, however, with our data for the week. We did have one additional person supported by DDA who tested positive this week. We continue to have one person who is hospitalized for COVID-related illness. 33 people who have tested positive for COVID have died. Of those, 31 so far have been determined to have been caused by COVID. There were 2 deaths that were people who had COVID, and the cause of death was determined to be something other than COVID. 139 of the 255 people who have had COVID have not required any inpatient care. 82 people have been discharged from the hospital. In terms of the type of placement, 4 people were in a host home, 86 in an intermediate care facility, 25 in a natural home, 2 were in a nursing home, 27 in a residential habilitation placement, and 111 in supported living. The one additional person this week that tested positive was in supported living. Unfortunately, this week we had 7 new staff, one of whom worked at more than one agency, who have tested positive. This brings our total in terms of staff up to 342 staff who have tested positive, 30 of whom have worked at more than one agency. For most of them, they worked at 2, and one person worked at 4 different agencies. And to date, unfortunately, among provider staff, we have had 8 deaths related to COVID. Just as a sort of a reminder, given that I don't see questions yet, as I've said before, it's not that we're waiting for the day when there will, when it will be sort of that we'll be back to normal. We are in our new normal, and our new normal, which is what we're existing in right now, will go on for quite some time. And given that, we need to all ensure that we continue to be vigilant about ensuring our own health, about taking the steps that are necessary to care for ourselves. Flu season will be upon us. We've all heard of the news recently about a surge in cases in Europe related to them being a little ahead of us in terms of flu season. We hope that all the people supported by DDA are consulting with their healthcare provider about the need for any vaccinations that they should be getting, and that all of our providers are continuing to be as vigilant, about the basics of all people who come to work are screened when they get to work, that people who are not feeling well are not going to work, that people are using face coverings, using masks regularly as required, consistently, using all necessary PPE, depending on the nature of the work that they're doing with people, to ensure their own health and safety as well as the people that we support. Fortunately, we have only seen one additional person test positive this week that we support, but then 7 staff people. It just reminds all of us of the need to constantly be vigilant, to care for ourselves, to take all the steps necessary to ensure our own health. So I see a question. Can we provide further guidance regarding COVID-19 testing requirements for people served returning to day services? Are people returning to services required to be tested for COVID-19? So all day providers were required to develop a day service return plan. DDS developed, along with some of our provider agencies, a best practice guide that identified 12 areas that need to be addressed in that plan, and then linked the provider to various resources that they could use in developing their own plan. In addition, DC Health has issued guidance for all adult day programs, which includes programs for senior citizens as well as programs for people supported by DDA. And neither the guidance, the best practice guidance issued by DDS, nor the DC Health guidance included a requirement that there be any pre-admission testing requirement for people that work in a day program or for people who attend day programs. With that said, each day provider developed their own plans. What I have heard from some day providers is that in their communication with people they support or those people's families, it's been very important to them that some screening be in place. And so there may be some day providers who will have a testing requirement. That would be in their day program. There is not currently a testing requirement either from DC Health or from DDS for day providers. I saw a comment from Daryl Hawkins that she's on audio, and if she's not a panelist, if we could please make her a panelist, and then
I'm working on it. I'm working on Director Reese. It's just taking a little bit of the time. I'm sorry.
So there's a question here regarding face shields and universal eye covering, and I'm going to leave that until we have Ms. Hawkins available, who is a really helpful support to us each week when the questions come up regarding health issues and DC Health guidance.
Daryl, you are now a panelist and should be able to unmute yourself. Please let me know if you can't.
Sure. Can you hear me?
I can. Thank you.
Okay,
Perfect.
great.
So, Daryl, are
Hi,
staff required to wear face shields / universal eye protection while driving? Staff have stated that a face shield obstructs their view while driving. Please advise.
Thank you. That's a great question. The answer is no, because it is as they mentioned, that's not safe for driving because of potential for fogging, etc. What we would suggest, though, that if you are driving, some of the guidances that DC Health have issued, not necessarily for this setting, but in general, when you're transporting an individual, one, don't transport anybody that is positive in a private vehicle. They should be going through MTA. Two, or medical transport specifically. And then two, if no one is symptomatic and no one is positive, that you consider that people still should wear. You should still wear a mask when you're in the car. You should increase ventilation in that car by either opening the window or changing your AC setting to allow outdoor air inside the car, and then still try to do 6 feet distancing in the car, meaning somebody not be in the passenger seat, everyone's in the back. But if this is a van, then maybe the distancing is possible too. Thank you.
Thank you.
There is another question about speaking more on face shields. I don't know what the more is, but there's a question: can you speak more on face shield requirements? So it's very general.
Yes. So with our updated return to work guidance, it does say that if you are going to be in any areas where there are any patient care or persons being supported care being done, or if any persons being supported is going to be around a direct care provider, that they should be wearing face masks, which is medical, so either surgical or procedural, and eye protection, and we consider eye protection to be face shields or goggles that are indirectly vented. And when I mean indirectly vented, they do not have holes in which, if something were to splash, that it goes inside the goggle. That is the requirement for that. I know that other individuals had questions about if the DSP, for example, is a household member of the person being supported. Do they need to wear the PPE? We consider, if you're in a household with someone else and that's your household, we don't, that requirement would not apply to those individuals. And I know that's not in our guidance, and I've talked to our group about trying to include that to clarify. Thank you.
And I see there's a question about which setting is this required, and that question was typed in while Ms. Hawkins was answering the question about driving. Everything I heard her say about driving people didn't sound different to me than the notice I've read in the back of an Uber, or any health guidance I've heard anywhere. And so it sounded to me, and I should let her speak for herself, but it certainly sounded to me like the guidance that she was giving regarding driving was guidance about driving people at any time. It's guidance, quite frankly, that people should adhere to at all times. As I had talked about earlier, we all need to continue to be vigilant. For that reason, when you get in an Uber, the windows are open, you wear a face mask. If you're in a car with people you live with, you have the same kinds of protections in place that you have in your home, which is you don't have a mask on if it's just, the household members in the car together. But if there are other people, then you would make sure there's ventilation, and to the extent possible, have safe distancing between people.
That is correct, Director Reese. And what I meant by it's written for other settings, meaning the driving is not specifically an ICF or CRF guidance, but it is the guidance for transporting any individuals in your car. And I'll take this opportunity to remind providers that if any of your workers carpool, for example, to remind them that they are not from the same household, and to follow some of those guidance that we just outlined on driving as well. Thank you.
And so I think there's a follow-up here related to face shields, whether this applies in supported living placements.
Hi. So the guidance for wearing eye protection is for any healthcare personnel. We define healthcare personnel as any individual who provides care services. So in that setting, the answer is yes, that does apply to any persons in supported living that provides care services to supported persons. Thank you.
Thank you, Daryl. And there's another question regarding MTM. Please clarify, I had a DDS SC during a CPAC meeting state that DDS has not approved MTM to reopen. I attempted to explain that MTM has been operating, and via this meeting, we were informed that MTM has continued to work. Another DDS SC today explained that she uses MTM for people supported and that they are operating. Can you share with DDS SC and/or clarify, as it is a barrier in the meetings and moving forward to return?
We will make sure that this is shared with everyone. Something can go out today sharing it. Many of the service coordinators do participate in this call, so I expect they would be hearing this now. MTM is not, they provide services for people supported by DDA, but they're not one of our providers. So they would not have submitted a reopen plan, as it were, to us. They are a DHCF provider. But as you know, MTM came to one of our forums. It's probably been 2 months ago now. Perhaps we could invite them back again, but they came to talk with people about the measures that they've put in place, to provide information about how to access the medical transport service. And they continue to be operating. They have operated throughout the pandemic. And so they are a service that is available, and Winslow or someone on his staff will make sure that something goes out to all service coordination today to make that clear.
Okay, and for in regards to DC Health, will there be any guidelines about people that may want to go on vacation with families during the holidays?
So I will say that I'm hoping this is for CRFs and supported living, because right now those that are in ICF settings, persons who live in ICFs, are not are not allowed to leave the ICF for non-medical reasons. However, for supported living and CRFs, we don't have any guidance about traveling with family. What we will say is that the mayor's travel guidance continues to apply to all persons who reside in DC. Thank you.
Yes, and I
Director
just
Reese?
want,
Yep.
yeah, I just wanted to sort of go back because I guess I don't think we forget, but perhaps we forget. We are still in stage 2. You can go to coronavirus.dc.gov and you'll see the metrics, how DC is performing to date in terms of, when we might expect to move to stage 3. But in stage 2, and it's been quite some time since we moved to stage 2, and so and we reviewed it then, but maybe it does help to kind of review what it means to be in stage 2. As part of the Reopen DC plan, out-of-town travel is discouraged in stage 2. And so, that continues to be the case. And, we'll have to see with the flu season coming, with the recent bump in the case numbers in the district. We don't know, but I would invite people to, the mayor has regular press conferences at 11 a.m. You can watch those. In addition, coronavirus.dc.gov provides daily updates on the status, and you can see there where we are in terms of moving to stage 3. And as a reminder to people, there is currently a mayor's order which lists a number of states, if a person were to travel to one of those states, what the requirements are when you return, which includes self-quarantining for 2 weeks. So travel during stage 2 in the mayor's reopen plan is still discouraged.
And Director Reese, if I would like to add that the most recent situational update that the mayor did provide gave some data on the trends in select activity types during individuals who are positive in DC overall. And one of it was travel. So about 17.6% reported that travel was an activity that they did 2 weeks before their symptoms or their positive test date. So that again underlines why what Director Reese just said with the data that we've been seeing from those that are positive in DC. And if you want to see that, that is the very top of the link of that website that Director Reese just said, which is coronavirus.dc.gov. Thanks.
And keep in mind, there's household members and then family members. The easing of precautions with the people that you live with and interact with every day is one thing. Having a big family gathering is a totally different thing. It's the same as any large gathering. Which is very difficult. I mean, I'm thinking about, in my own family, sort of planning for birthdays that are coming up that are milestones, Thanksgiving, Christmas, the beginning of the year, a lot of different typical events that would occur that are going to be different this year.
And I received a note, Andy, if you could asking if you can repeat the COVID data at the top of the meeting.
Sure. So, as I said, we to date have had 255 people who have contracted COVID. Of those, one person is still hospitalized for COVID treatment. We have another person who's in the hospital, but that person learned they had COVID when they went to the hospital for another reason. So they are not hospitalized with COVID. And throughout, there have been a small number of people who had to have medical procedures or went into the hospital for another reason, got a COVID test, and it was positive. So when I report the numbers, just so that people know, I do not include them as someone who was hospitalized with COVID. I include them as someone who did not require inpatient care for COVID, because just like this person, they didn't, they're not receiving any COVID related care. So to date, of the 255 people, 33 have died. We have learned that 2 of those deaths were not COVID related since the report from the Office of the Chief Medical Examiner was received. There are still 4 deaths that there are questions about. And so as we receive the reports from OCME, we may be updating those numbers further. 139 people have not required inpatient care for COVID, and 82 have been discharged. Of course, of the 33, many of those did require inpatient care. So I think 4 of them did not get to the hospital. I was looking at that data this morning. So not all 33 died after receiving inpatient care. In terms of the type of placement, there were 4 people who were in a host home, 86 in an intermediate care facility, 25 in their natural home, 2 who were in nursing homes, 27 in residential habilitation, and 111 in supported living. And in terms of provider staff, there have been 342 provider staff who have tested positive to date, 7 in the past week, which is a real concern. 30 out of those 342 have worked at more than one agency. And sadly, we have seen 8 deaths amongst provider staff.
Okay, I don't have any other questions in my queue at this time.
Director Reese, if I could just provide a reminder to all providers, if there's someone in your organization that would like to join these weekly calls, please forward the information to them, the invites on a weekly basis. We get a lot of requests, and it's hard to meet all those requests in a timely fashion. So please forward internally within your organization if there's anyone that needs this invitation weekly. Thank you.
I see a question. Can we initiate a disciplinary action if a DSP is sick and refuses to stay home? In fact, if we receive a report that a DSP comes into work sick, or frankly, if we receive a report that any of the required COVID mitigation measures are not being implemented in a particular placement, we will enter a serious reportable incident, and we will investigate that as neglect. So, what an individual agency does in terms of disciplinary action is up to that agency. But when I have seen instances where there's a question about whether DSPs are wearing whether they're wearing the necessary face covering or face mask. If we get a report of a DSP who, felt sick, and so they got tested and they continued working and then got the test results and it was positive, so they stayed home. In those instances, we will be talking to the provider agency to learn, what did you know and when did you know it? Did you understand that the person was sick and was tested, in which case, until we learn otherwise, then we're presuming they're positive and they should be self-quarantining at home. And in the same instance, so anyway, and then after that, did the person tell the provider agency? So it's going to be very important, that the guidance is out there. And so people need to be paying attention to, as I said earlier, continuing to be vigilant, continuing to implement all of the necessary mitigation strategies. When you look at our data in terms of the COVID data for people supported by DDA, our peak was in April. And out of these 255 people, about 140 of those positive results occurred in the month of April. And then a much lower number in May. And ever since then, we've seen very low numbers. In order to maintain those low numbers, we really have to maintain all the measures that were put into place beginning in about the middle of April. So there's a comment saying a new COVID policy stating that a DSP feeling sick should not come in when feeling sick. I'm glad if you're referring to a policy at your agency. I believe it's been an expectation from the beginning. I see a flyer in our kitchen that was first posted here at the office back in March that says, if you're sick, stay home. And I believe that has been the message from the very beginning. And I will say on that note, since there isn't another question, I did notice today on the coronavirus website, the average time to get a test result is 2.5 days. So when someone is being told to stay home, if they're sick and got a test, it doesn't take long before they get those test results.
Director Reese, can I also add something as a reminder to providers that we have noticed for other healthcare personnel? One is, while it isn't a requirement per our guidance, we want all the providers to strongly consider adding exposure questions to your regular symptom screening. So meaning asking your direct care providers, do they have any known exposure to a positive individual? And if that's the case, they should also not be coming to work. And the same for the travel, to consider adding those. And to reinforce that with your providers as well. So, for example, if your providers decide to get tested for COVID because their friend told them that they're positive and they were exposed to that friend, that they should wait and not go to work until they get those results back. So basically, it's assume you're positive until you're proven negative. Do not come to work, because in many different healthcare settings, we've had a couple of instances where healthcare personnel went to work after getting tested because of an exposure in the community, and there was some unnecessary exposures in that healthcare facility because they ended up testing positive. So please remind your providers that. Thank you.
Thank you. And the other important thing there is if someone has an actual exposure, they are self-quarantining for 14 days. So if they learned that they were in personal contact with someone diagnosed with COVID, even if they got a negative result, the self-quarantine is still the 14 days, right?
Correct. And actually, our guidance says that healthcare personnel who have a COVID-19 exposure in the community must be restricted from work, even if they are asymptomatic. And any healthcare personnel that have symptoms that are consistent with COVID-19 symptoms, if they refuse to get testing, for example, that they are still going to our guidance says that they should still stay home, and we will. They can only return to work if using the symptom-based strategy, even if they refuse testing. So that's if, again, underlining, if someone is symptomatic, they should not come to work. If they had exposure in the community, they should quarantine for 14 days and not come to work. Thank you.
And I think the really important issue that you raised that we are going to put on our agenda to discuss for Monday morning to review is I meet with the leadership team here Monday. That was the agenda. Everyone on the call in the participant or the panelist side understood that. So for the community to understand, I think that the recommendations we currently have that we sent out to providers regarding screening were written back in April when they included reference to travel overseas. So I think that we really need to take a look at those and make sure that they've been updated to include the most current recommendations and I know from hearing from our providers that the ones I've heard from have been updating their screening to keep up with current guidance. But we will be taking a look and, if necessary, issuing new guidance to make sure that providers are doing all the appropriate screening. And I'll also say, given the limited number of questions, in some of the conversations with other folks, not just providers or otherwise, people do their own screening in terms of who comes into your home. I mean, I can't emphasize enough the importance of all of us staying healthy in order to prevent the spread of this disease, because, the fewer of us that have it, the less likelihood that someone else can catch it. And the steps that all of us can take to reduce transmission are really important.
And Andy, I received just an announcement for providers. Please be sure to attend DHCF's EVV stakeholder meeting next Monday, October 19th, 11 to 12. There will be important information, dates for provider training that will be shared. And also, I received a note that some folks have been having challenges accessing Webex at these forums. So if you can just type what challenges you're experiencing, perhaps we may need to troubleshoot with our Webex guru. So if you have been experiencing challenges, maybe you had to attempt a few times to access this forum, if you can just let us know in the chat box. And a question that we just received: what's a sample of the best contact tracing mechanism providers should use if they get a positive case in a residential or day setting?
I'm pausing to allow Daryl to answer, given that she is from EPI, but I will also say, first is the requirement to enter an incident in our system. We coordinate closely with EPI and in fact meet every week with them to talk about this issue of contact tracing in our placements, but perhaps she could speak to exactly kind of what the process is for contact tracing once the positive report comes in to us and is then communicated to DC Health.
Yes, thank you, Director Reese. So we do say that, one, if there is a positive, let's say, staff that tests positive, whether it's in DC or Maryland, that positive lab results gets funneled to that specific state's contact tracing team from that health department. And from there, they will do their own individual interviews of those individuals about all of their exposure in their personal life and at work. However, I would say that what we often tell healthcare facilities and even in your setting is that internally you should identify a process in place for you to do that. Obviously, you can always reach out to us if you need some guidance or help on setting up that process. But from the facility standpoint, just doing contact tracing on who that individual had close, meaning less than 6 feet, prolonged, 15 greater than 15 minutes contact to individuals while working for that facility or for your agency, for both the patients, not patients, person supported, and other direct care providers. So that as that's really the system, meaning you, for facilities, do your own internal contact tracing of any persons that were in contact with a positive individual in that work setting. And then to reach out to us if you have any questions, and also DDS to report some of your findings. And I hope I explained your process, Director Reese, properly.
Yeah, thank you. Because the other issue that comes up a lot is that one that you raised of, close personal contact. So, it's contact with a person who had COVID. And yeah.
I will underline some of the common pitfalls that we have found. One, contact tracing is not to find out who patient 0 is. We're not trying to find out how they got it. We're not doing their personal life. We are really, the purpose of contact tracing is to mitigate the spread, prevent further spread. So trying to figure out who was exposed to the positive individual. We do not quarantine people who are exposed, not positive, and people who are exposed to that. We call that contacts of contacts. Those individuals are not part of the consideration for quarantine. It's only individuals who had close, less than 6 feet, prolonged 15 minutes or more contact with the positive individual. Thank you.
Thank you. And we typed in the information about the electronic visit verification meeting that will be occurring at by DHCF in the chat box for people. And that's on the 19th from 11 to 12 for people who are participating by phone and can't see the chat.
Director Reese, someone sent a chat, but I think it might have only been sent to me, a question. Even if a provider discourages from travel and large family gatherings, there are some persons supported that will still insist it is within their right. As a provider, then, is it within our provider rights to mandate a negative test result before returning to the provider?
No. So it's a really interesting question. And what it raises for me is we have been having, and the reason I say that is, when people go into the community, you can't then refuse to allow them to return to what is their home. With that said, when people are planning these kinds of things, you can talk to them about what it will mean. So, so that, for example, I know that we had a conversation with one provider, and I don't know ultimately where it landed, where they had made plans in February for their typical summer vacation, and they were going to take a group of people, which included people from different homes, to a house at the beach, and they talked about how they would, how they might manage whether the people would leave the house, what kinds of contacts they'd have, how they would then manage when they returned, how they would essentially sort of quarantine the people who had been on vacation together, but separate from their household members. So at DDS, we have a regular it's a discussion. I'm the one that always says, don't call it training. So we have developed, along with a group of folks who've helped us, who've been from the advocacy community, family members, people we support, providers, where we've developed a PowerPoint to facilitate a discussion about these kinds of issues of people's rights during COVID. So can a person say, it's my grandmother's 90th birthday, I'm going to attend her 90th birthday? Yes. Can you, see, because here's the thing. The people we support have the same rights that we do. When the mayor issued a stay-at-home order that said that all people in the district are to stay at home except for engaging in essential activities, that meant all people. And that ended in June. There were some aspects of it that have continued. There continue to be some restrictions that I may see some comments now in the chat regarding there continue to be some restrictions for people who are at higher risk, at highest risk really, for serious outcomes from COVID, who are in intermediate care facilities in terms of travel, in terms of having visitors. But even there, they continue to have their rights. People who live in a residential habilitation placement or supported living, any one of us, you know, I received, and I'd be happy to share with people actually, Ohio put out guidance about how they manage people's rights during COVID. And their guidance was a very nice kind of 2-page document that includes pictures. And one of the pictures was a big family birthday party. I was frankly horrified. The idea of 25 extended relatives going to visit with their grandmother, who appeared to be, you know, turning 90 or 95, and all of those people coming in contact with her. It's not the way that I would show my care and concern for an older family member. And so, you know, I think everyone in that equation had a decision to make, including, you know, the grandmother may have said, I want this birthday party. We don't know. But like I say, everyone has to ensure their own health and safety. And when such an event is occurring, there needs to be a discussion about it. And the purpose of the training that we have, and maybe if someone's here who can post for our providers how they can, if they haven't received, I think they have, the schedule of when these discussions occur. They're currently happening, I think they're happening is either weekly or every other week. And they discuss exactly this kind of issue. If a person says, you know, I want to go do this event with my family, then there is a discussion about the risks to the person. You know, is the person someone who's at higher risk for serious outcomes? What about the other people that live in their home? What about the staff that work with them? Having a discussion with people about not just what are my rights, but what are my responsibilities. And it's not legal responsibilities. It's, you know, like I wear face covering all the time to protect other people. It's legally required. But the more convincing matter was it keeps me from giving something that I might not know I have to other people, sort of a moral responsibility to others. And so, you know, the reason that we started having these sessions with people is to give our provider staff the information, the skills to have the discussion with the person about all the factors involved, including if you do this, what's it going to mean? So, for example, if this family birthday party was in one of the states that's listed in the mayor's order that says, if you go there, you must self-quarantine for 2 weeks. How's that going to look when you come back to a house where other people have not gone? To me, and maybe Daryl could weigh in on this, I think that would mean, you know, if you're in the room with other people, unlike typically, you're going to need to be wearing face covering because you're going to need to quarantine for 2 weeks from folks who you haven't had contact with because you might have brought something back. And so it's really having that whole discussion. Can the provider just say, well, you can't come back here for one until you test negative? No, that's not it at all, because suppose they just go ahead and get a test and it's negative and a week later they're positive. So the rules about traveling out of town are, if you go to these certain states, when you come back, you self-quarantine for 2 weeks, and it's the 14-day self-quarantine. And I think that what you have to talk about is if you're in any kind of a shared living thing, how do you ensure the protection of the people that you share that living space with when you return home? But they are discussions that need to happen. And I will say, in developing the PowerPoint, we had really great discussions all along the way, considering all these issues. And I think they are really challenging issues. And so I would really invite people to participate in those discussions that we have, because it is important to really be comfortable talking through all of these issues as people make these decisions.
Andy, in the chat box, I included a Zoom link to Project Action's meeting tomorrow. A few weeks ago, one of the leaders or two of the leaders had requested support from providers so that people can access the meeting. And I put the link in the chat box for you guys.
And I would really encourage our providers to make this accessible to folks you support who are interested in attending a Project Action meeting.
Hi, this is DC Health, Daryl. So I just wanted to add on to the quarantining. I will say one director, Reese, described it perfectly. You cannot test out of quarantine. So even if they came back with a negative test result, they will still need to quarantine, as he mentioned. And from our end, just keep in mind that any individuals that are under quarantine, so whether that's because of travel, as we were mentioning, or let's say you had a new admission, for example, to a new person who's going to be coming into the home, that those that are under quarantine, it is required that those who are providing direct care to them wear the full COVID-19 PPE. So that includes eye protection, face mask, gown, and gloves. Thank you. When entering that person's care area.
So I see a question. It's a question for DC Health, but it looks more for Sharon Mebane. You may be able to answer it, Daryl, asking if DC Health were to learn that a person in an ICF chose to go to their grandmother's 90th birthday party, would DC Health make a finding against that ICF for not following the ICF guidance that DC Health has issued? And that may not, I don't know if, I know that those would be the kinds of issues Sharon Mebane would address for us, but if you know what their action would be.
I'll let Sharon Mebane and Herla determine that. I will say from our end, our guidance is when it says must, it is a mandate from DC Health. But what Herla will do based on that, I will let Sharon Mebane answer. If she's not on the call, I'll let her know that this was a question, and maybe we can follow up next call. Thank you.
Thanks. So the next question, I'm going to defer. I think Winslow is here. During COVID-19, if waiver issues a companion service authorization using a regular modifier, do we still have to utilize instead the Appendix K modifier for companion to bill? It says you're speaking, Winslow, but I don't hear you.
Right. It figured it out. It's doing its own thing. So when you bill, if you are during the public health emergency, you should use the CR modifier to bill to receive the enhanced rate. So the answer to your question is yes, you need to use the modifier that's in the Appendix K.
So the next Assuring Rights During COVID discussion is scheduled for October the 28th at 9 a.m. And if people are interested, they can contact DDS, I believe, and we will provide a number or email address for them to contact. Fakisha Guy at DDS. And providers contact Fakisha for scheduling training all the time. So I'm not providing her contact information this moment because I don't have it this moment, but she's the same person you've been contacting for quite some time. And a reminder notice will be going out about that October 28th discussion before that date. That'll go out to all providers. So for Winslow, will that also apply to in-home support extension using the Appendix K modifier?
During the public health emergency, all of the services listed in the Appendix K need to be billed with the corresponding modifier to receive the enhanced rate. All services listed in the Appendix K need to have the appropriate modifier to receive the enhanced rate.
And the email address for Fakisha Guy is FIKICIA.guy, GUY, @dc.gov.
And I don't have any questions in my queue at this time.
So Winslow, here is the issue. Once the total number of units is exhausted, the provider is not able to bill.
What happens in that case is I would have to give the waiver unit approval for an extension because these are unique situations, and there are people who are in some cases exhausting the number of hours. It's absolutely amazing to me. But we would like to handle those cases as they come in individually, because not everyone is exhausting all of their hours, and they have to have approval for an extension.
There's another billing question, Winslow, which
Does
is
in-home support and companion have enhanced rates for non-COVID positive, non-quarantine persons? Oh, okay.
yes.
So yes, all those services, the rates were enhanced because of the public health emergency. And yes, if a person is positive, there's a different rate. So yes.
I think what you just need to do is go back to the two transmittals that have gone out along with the Appendix K that we have sent out and read through, because those include a summary of all of the enhanced rates that were established during the public health emergency, and review those. And then if you have questions, you could raise those specific questions. Someone said there was supposedly a training today with DHCF on billing but with no link. Were we aware of this training?
I had no knowledge of any training on billing, but the appendixes were, the transmittals relative to the changes in the appendix were issued on April 30th and June the 11th to all providers to the email of record. One of the things we've seen as a challenge is that the email of record may go to a person who has no responsibility or is not the person who does the billing for the company. So we encourage providers that whoever receives emails on behalf of your company shares that information throughout the your agency or with the person that does your billing.
Winslow, I'll also follow up on that and say that all of our guidances, whether health related or billing related, are posted on our website, especially under the coronavirus related pages.
So I see that it is 1 o'clock. We don't seem to have any other questions. So with that, I'll thank everyone and have a safe weekend, and we will talk again next week. Thank you very much.
See, someone is calling.